Thanks so much. Good morning, everyone. And thank you for joining us for this Opioid Education Foundation of America webinar, COVID-19 and the Opioid Crisis, the Perfect Storm. We're so pleased to have representatives with us from 45 states, so thank you for being here, as well as from the island territory of Guam. And I thank you all for being here, for your commitment to eradicating the opioid crisis that's impacting so many. Well, the focus this year has rightfully so been on the COVID pandemic. We know that the opioid crisis continues to rage, and it is in fact fueled by the stress and isolation that the pandemic has brought with it. The Opioid Education Foundation of America is dedicated to finding solutions, and we do that through education opportunities for legislators, professionals, prescribers, and families, and through advocating for legislative efforts such as the patient notification law, which has been passed in 18 states already across the country, and it requires that at the time an opioid is prescribed, a patient or the patient's parents will be notified of the potential for addiction and alternatives that exist. Today we'll hear about the state of the opioid crisis, how we got here, what we can do from our keynote, Dr. Andrew Kolodny. Dr. Kolodny has researched the impact of the patient notification law and will speak to the benefits of that law, and we thank him for being here today. We'll also hear from Congressman David Trone from Maryland's 6th District, who is working to make this a national effort. And so to begin, I'm so pleased to introduce the founder and chairwoman of the Opioid Education Foundation, Elaine Pazicki. Hi, Elaine, and welcome.
Hi. Hello, everyone. Good afternoon. And thank you all for joining us today for this important conversation. My name is Elaine Pazicki, and I am the founder of Prevent Opioid Abuse and the Opioid Education Foundation of America. Both are national organizations working to educate providers, policymakers, patients, and parents about the risks of opioid-based painkillers and the availability of non-opioid alternatives, and developing solutions to the opioid epidemic that is claiming lives every day and devastating families across our country. My family, like so many other families, was devastated by the loss of our son Stevie to this opioid epidemic. Stevie developed a dependency and addiction to opioids after they were prescribed following a sports injury. When he was prescribed these powerful drugs, neither he nor I were given any information on how addictive these drugs could be or how fast a dependency begins. I truly believe that had my son or I been told of the potential for dependency or addiction of the opioids he was prescribed, that he would be alive today. Had I only known how addictive these drugs could be, I would have decided to look for alternatives and understood how addictive they truly are. And I absolutely would not have picked up those prescriptions. I had no idea that those prescriptions for opioids I was picking up to help my son actually had the same effect on his brain and body as heroin. If his doctor had been required to have this simple conversation, I would have known how addictive opiates are and would have looked for alternatives, and I would have known I needed to get him help earlier, since we now know dependency to opioids can begin after 3 to 5 days. And I am not alone. A national survey done by the Hazelton Betty Ford Foundation confirms what I have learned from talking with other parents, that 6 in 10 doctors prescribe opioid painkillers without telling patients that they can be addictive. That is why my organizations have been created to support and advocate for legislation that is so important if we are going to curb this epidemic, save lives, and prevent countless families from this unbearable heartache that will never go away. Since Stevie's death, I have committed myself to ensure that no other patient or parent of a patient receives a prescription for an opioid without first being told by their prescriber of the addictive qualities, because we all have the right to know the medications that they're about to receive can lead to addiction. Patient notification legislative efforts at both the state and national level have been introduced. And on the state level, 18 states have adopted the legislation. New Jersey was the first to pass the law, and today we are going to hear about the incredible outcomes of that legislative public health effort by Dr. Andrew Kolodny, who leads the research on its impact. My goal is to bring this legislation to all 50 states to help protect other families. And I urge you today to take a big step towards protecting the families and residents of your community and join in sponsoring and supporting legislation that requiring a conversation between doctor and patients and parents of patients before an opioid painkiller is prescribed. Most especially now, as the COVID pandemic has contributed to record opioid overdoses. I am so proud to report that through the leadership of Congressman David Trone from Maryland's 6th District, national legislation supporting the efforts of states who pass notification laws will soon be introduced. I am so pleased that Congressman Trone could join us today, and it is my pleasure to welcome him now. Welcome, Congressman Trone, and thank you for all you are doing to save lives and protect families from the opioid epidemic. Thank you.
Thank you very much, Elaine, for inviting me here today to speak with you, and thank you and everybody on this call for all that you're doing to help us with what's clearly after COVID and the financial crisis are past, and they will pass because we know a vaccine is coming, but there'll be no vaccine for addiction. This is going to be a long, ongoing battle with a million different things we need to do to be successful. And your work here is absolutely crucial, and 100% lives will be and have been saved. So thank you very much. I lost my nephew to an overdose of fentanyl in 2016. So we're coming up on the 4-year anniversary of his death. My family, my wife and I and children watched as he battled addiction for over 5 years prior to his passing. We know firsthand, as so many of you do, the challenges and what it's like to lose someone to this terrible, terrible disease. We've been into the trenches, seen all the difficulties and the obstacles. So we know that this crisis doesn't care if you're a Republican, a Democrat, an independent. It impacts every community in America. It's my number 1 issue here in Congress. It's also my number 2 and 3 issue here in Congress. Then after that, we're working on mental health and criminal justice and their connectivity points to the opioid addiction. I'm proud to say we've made a lot of progress, but we have a lot, so much more, including your legislation, that we've got to do over my first 2 years here in Congress. We started off by trying to draw attention and get people to realize that this problem is so severe. We've now lost 550,000 Americans since the year 2000 to overdoses. Staggering, double the number of what we've lost to COVID so far. So by initially trying to draw attention and talk about the stigma, we hosted something we call Congress Goes Purple during Recovery Month. We've also visited treatment centers to hear directly from those with substance use disorder. At Congress Goes Purple, we had everybody from Speaker Pelosi to over 100 and some members involved to drive awareness. But the most important thing we did was right out of the gate, we built a cohesive group that all had the same mission We put together 65 fresh men and women legislators from 32 states and began to educate them with an ongoing series of meetings about what opioid addiction is doing to our country and looking for ideas of how we together as a team, a bipartisan team, can address this. Since then, we put together a little over 50 bills, all bipartisan, on addiction and mental health because they're so inextricably connected. I'd like to talk briefly about two of those bills that just passed unanimously the House of Representatives last month, and we're working in the Senate with bipartisan support again to get over the finish line. The first is the state opioid response grants. When I came to Congress, I spoke to Maryland's Governor, Larry Hogan, my state, county leaders, hospital administrators, direct providers, and stakeholders from Georgia to Kentucky to North Dakota. First thing you do is we understand the problem at a deeper level. I bring a business background to this, having been self-employed and an entrepreneur for the last 30 some years and building a business across this country. So I understand how to bring people together for a common goal, set out our vision, and create steps so we ladder up to get results. We work with the treatment centers across our district, and they all have the same message. We need consistent funding. We don't need 1 year and then hope for next. Hope's not going to save any lives. We need consistent funding. So this bill authorizes $9 billion over 6 years and flexible, and the key is flexible, spending for states and tribes to fight the opioid epidemic on the front lines. Each state needs different treatments. Second bill that we passed came out of the fentanyl. It's called the Fentanyl Results Act. In 2019, 71,000 deaths, an overdose in the United States, the highest number ever. And fentanyl is showing up in more and more of these deaths. It's coming from China through Mexico. It's, as we all know, 50 to 100 times stronger than morphine and cheaper, so more profitable for the cartels. Our bill would build international cooperation to crack down on fentanyl in the synthetic drug trade. Earlier this year, I was appointed to a commission by Speaker Pelosi. As one Democrat in the House, we have one Republican in the House, one senator in each, 4 outside experts, and then all of the major executive branches, the head of ONDCP, Defense, Treasury, DEA, everybody that can really bring us a all government, all hands on deck approach. We're looking forward to coming up with a bipartisan solutions from this working group in the next year or so. So clearly COVID has been a disaster, as was mentioned, on the opioid epidemic, and it couldn't be more dire than it is right now. Over 40 states have reported an increase in overdose deaths since the start of this pandemic, on top of an already record number of deaths. Social isolation from COVID-19 has made it even worse. Calls to the disaster hotline are up over 900%. Over half of US adults in a recent survey said they're worried, stressful, anxious, that COVID has led to at least one negative effect in their mental health and their well-being. Because of this, people are taking substances to cope. In my district alone, our numbers are up in every single county, some by high as 54% in Western Maryland. It's devastating. The issue demands bold action. We're working hard to include COVID in the COVID relief bill that will pass next week, an additional $5 billion toward an addiction package for those suffering. We're also working on your bill to encourage states to adopt policies that require providers to discuss with the patients. It's such common sense. The work you've done in New Jersey and other states has led the way. But our bill needs to talk about, providers need to talk about the addictive nature of opioids and, of course, alternatives before giving that first prescription. The bill would provide funding to states that have adopted those policies that they can use to provide information about the state's requirements and share recommendations for safe opioid prescribing. Luckily, we have a new administration coming in. I worked early and often with the Biden team and was a big supporter. We've been working with their policy group closely the last 3 to 4 months. They understand the impact that this virus has had on addiction. It's like rocket fuel. We're confident the Biden administration will have at the top of our agenda, their agenda, after COVID and the economy, addiction and mental health. President Biden-elect, his family has experienced these things. We're all in this together. Together, we're going to find a vaccine for COVID, but of course, no vaccine for addiction. So that's why we need to act now. And I look forward to working together. We really need your ideas. We really need your input. In business, I learned all the best ideas come from the folks on the front lines. So we've got a whole staff and now a commission driven, focused, relentless on this disease. But we need your input. So I ask you, as time goes on over the next year plus, bring to us, as you have in the past, your ideas, and we can help make them into legislation. So we really look forward to work together as we fight this scourge of addiction during this pandemic and beyond. So thank you very much for coming together today.
Thanks so much, Congressman. Appreciate your support, your efforts, and your leadership on this issue. And so now it is my pleasure to introduce our keynote speaker, Dr. Andrew Kolodny. He is the co-director of opioid policy research at the Heller School for Social Policy and Management at Brandeis University and executive director of PROP. Welcome, Dr. Kolodny.
Thanks for having me. So I'm going to get started. I'm going to begin by saying something that should be obvious, but it really isn't, and it's not even obvious to many doctors who prescribe opioids. When we talk about some of the most commonly prescribed opioid pain medicines, drugs like oxycodone and hydrocodone, we're talking about medications that are literally made from opium. You need opium to make OxyContin and Vicodin and Lortab and Norco. Those are what we would call semi-synthetic opioids. So you start with the opium occurring naturally inside that opium, which is the sap from the poppy plant, is codeine, morphine, and thebaine. They exist naturally. Another term for the natural opioids is opiate. Those are the true opiates. And it's from those opiates that we make semi-synthetic opioids like heroin, oxycodone, hydrocodone, hydromorphone, and oxymorphone. So from the opiates, you make semi-synthetic opioids. You also have completely synthetic opioids like fentanyl, methadone, and tramadol. And opioid is really the all-encompassing term that covers everything I've just mentioned. Now, one of the important points I want to make at the outset, and this was something that Elaine mentioned in her opening remarks, is that when we talk about the semi-synthetic opioids, drugs like oxycodone and hydrocodone, you're talking about drugs, molecules that are very similar to heroin. When you create a semi-synthetic opioid, what you're really doing is creating a molecule that dissolves in fat more easily. The brain is mostly composed of fat. And so you're creating molecules, the term we would use is lipophilic, fat-loving, molecules that cross the blood-brain barrier more quickly, that have a more rewarding effect, that are more potent. So that's why, if you've ever wondered why cartels would go through the trouble of converting the opium into morphine into heroin, it's because you're creating a drug that's more potent with a more rewarding effect. And that's essentially what you're doing when you make oxycodone and hydrocodone. You're making drugs that are essentially the same as heroin, that get into the brain very quickly. And when we talk about opioid pain medicines, we're essentially talking about heroin pills. Now, to make such a strong statement doesn't mean that doctors should never prescribe opioids. These are very important medicines for treating pain at the end of life. But it does mean that we should prescribe them very cautiously. And unfortunately, the medical community in the United States continues to prescribe opioids much too aggressively. And I'll share some data with you on that in a little bit. So this is also something that should be obvious. Why are opioids highly addictive? They're highly addictive because when you take them, they have a rewarding effect. Either they make you feel good, or they relieve pain, or they make you feel less anxious. And because they have positive effects, basically rewarding effects when you take them, that might make somebody inclined to take them repeatedly. Now, if you take an opioid repeatedly, then once you stop taking the opioid, you will start to feel negative symptoms. So take them repeatedly, physiological dependence on the drug sets in, try and stop taking them, and now you have a negative reinforcement for stopping, which makes you want to continue using. That's why opioids are so highly addictive. Now, how do people get addicted to opioids? And again, this is something that should be obvious. You become addicted to highly addictive drugs by taking them repeatedly. Now, there are addiction experts out there working for the opioid industry, even testifying in court in some of the state lawsuits against opioid manufacturers, who would try to have us believe that this isn't true, that addiction doesn't develop from repeated use of opioids, that that opioids are not inherently addictive, but that addiction somehow resides in the individual, that there's a subset of our population that are prone to addiction, and everybody else could take opioids as much as they want, and we have nothing to worry about. In other words, that duration of use has little to do with addiction. That is not true at all. That would be true if we were talking about other drugs, but it's not true for highly addictive drugs. When it comes to drugs like nicotine, heroin, oxycodone, hydrocodone, with highly addictive drugs, repeated use leads to changes in the brain that can result in addiction in almost anyone. What is the opioid crisis? I think we all have a sense of what we're talking about when we use the term. We're talking about the large number of overdose deaths. We're talking about infants born opioid dependent, children winding up in the foster care system, impact on the workforce. We're talking about basically all of these different health and social problems that are opioid related. But what's the right way to frame this issue? Well, let me start by saying what the wrong way to frame the issue is. The wrong way to frame the issue is as an epidemic of drug abuse, as an epidemic of opioid abuse. When you frame this as an abuse problem, I think what you're suggesting is that the problem is we have a lot of people out there behaving badly. They're taking these drugs because it feels good, and they're accidentally killing themselves. And if you frame it as an abuse problem, then the challenge is, how do we get people to stop behaving badly, or how do we get people to stop abusing these drugs? Maybe we make them abuse deterrent so that they can't be crushed for the pills for snorting, as if the whole problem is all about abuse. We don't have an epidemic of abuse. What we have is an epidemic of opioid addiction. The correct way to frame the opioid crisis is as an epidemic of opioid addiction. Now, it is true that some people become addicted because of abuse. Some people became addicted because they liked the way the drug made them feel, and they did that too much and they got hooked. Other people, though, became addicted taking opioids as prescribed to them by their doctors, regardless of how someone becomes addicted, even if their addiction began through abuse. Once that individual becomes addicted, what drives the continued use more than anything else is that without the drug, as we've talked about, people feel awful. They feel really sick. There's that negative reinforcement. And when I say people feel sick, I'm not just talking about the flu-like symptoms of opioid withdrawal. I'm talking about also the very severe anxiety that kicks in when people are going into withdrawal, the excruciating pain from hyperalgesia that can kick in when they're going into withdrawal. When people are going into opioid withdrawal, they can truly feel like they're going to die, which is why very good people will sometimes behave very badly in their effort to maintain their opioid supply. They're not doing this because it's fun. They're doing it because they're addicted. The opioid crisis should be understood as an epidemic of opioid addiction. And I'm going to show you that epidemic happening. This is 3 years into the epidemic. I believe our opioid addiction epidemic began in the year 1996. So this is 3 years in. This is 1999. The states that show up as red or maroon are the states with the highest rate of individuals seeking treatment for addiction to prescription opioids. Now, watch what happens as we go forward in 2-year increments. You see, this is 2001. You have many more states that turn red and maroon at 2003, 2005, 2007, and 2009. What you can see is that in just about every state in the country, we've seen a very sharp increase in the prevalence, the number of people seeking treatment for addiction to prescription opioids. When you have a sharp increase in a disease over a short period of time, that is how you would define an epidemic. Now, when you have a sharp increase in the prevalence of a life-threatening condition, and many people with that condition do not receive effective treatment for the condition, you also see lots of people dying from it. And from 1999 to 2010, the vast majority of opioid overdose deaths, which were occurring mainly in people addicted to prescription opioids. Not everyone who dies of an opioid overdose was addicted, but studies indicate that most of the people dying were suffering from addiction before their death. From 1999 to 2010, what was really driving the increase in drug overdose deaths in the United States is the red line, and that's prescription opioids. Heroin, which is obviously an opioid, is shown in green at the bottom. And you can see cocaine coming up and coming down, and it's also come up a little bit again in recent years. Cocaine has been somewhat cyclical for many years, and you do see also this disturbing trend with regard to benzodiazepines, drugs like Valium and Xanax and Klonopin. These are prescription medicines for anxiety that are often involved in an opioid-related overdose. By themselves, they rarely cause an overdose, but when mixed with opioids, they make the opioids more lethal. So this is what the picture looked like up until 2010. And as many of you know, what's really changed, and as we heard Congressman Trone explain, in recent years, what's really been driving the increase in many states has been fentanyl. Now, this graph that you're looking at is showing you what's happened since the 2010. And you can see with the gray line, prescription opioid overdoses. And you could see that around 2011, it stopped going up as quickly. And around the same time, you see the dark green heroin line going up. And then you see a few years later, the dark blue synthetic line. So the gray line, by the way, on this slide says natural and semi-synthetic opioids. That's prescription opioids. Then you have heroin in dark green and fentanyl in dark blue. And what you could see is, after, certainly since 2015, what really drove that increase was illicitly synthesized fentanyl. Now, people have been looking at the trends on this graph and drawing some of the wrong conclusions. You will sometimes see these trends framed as three waves of the opioid crisis. You'll hear people describe the prescription opioid wave, which would be the gray line, the heroin wave, the green line, and then the fentanyl wave, the dark blue line. And some people are also now even talking about the fourth wave being methamphetamine. Now, I don't think it's actually very helpful to try and frame this using this waves analogy, even though when we look at the national data, one could make the case. But the looking at the opioid crisis by simply focusing in on the deaths only shows us one piece of a broader picture. And when people describe this as three waves, what I think they're implying is that people who are drug users in the United States are fairly homogenous, and that they've been shifting from one drug to another based on availability. And that really isn't what's going on. There's some truth to that story. The truth being that the overwhelming majority of individuals who started to use heroin after 1996 were first addicted to prescription opioids, but the switching doesn't really happen when the deaths start going up. If you look at this graph, it looks like heroin starts going up in 2011 and then fentanyl in 2015. The switching from prescription opioids to heroin actually starts to happen in the early 2000s. What you're seeing here are the deaths going up, not necessarily points in time when there was sudden switching from one drug to another. Using this three waves based on the national data is also really obscuring very important state-to-state differences. Now let's just look a little bit more at more current national data, and then I'll show you what's happening on a state level. This graph ends in 2018. This is put together by the CDC. It was published in 2020, which means really nearly a 2-year lag in the data that the CDC is publishing. For the more provisional data, you can go onto the CDC's website. That's what you're looking at here. And it's showing you what's been happening with opioid-related overdose deaths up until April of 2020. Total opioid deaths on this graph is shown as black. Fentanyl is in brown, and prescription opioids and heroin are in blue. Prescription opioids are orange, heroin is blue. And what you can see here is that what's been driving the increase, the national increase, really has been fentanyl. You see that in 2019, unfortunately, opioid-related deaths went up a tiny bit. And you could see the beginning of January 2020, and with maybe a month or so of data here representing COVID, you do see fentanyl deaths going up. You see the total going up. You do see evidence that the opioid crisis has gotten worse. There is more evidence on a state level, and you can get more current data. Some states are making more current data available if you go to the right website for a state. But for nationally, this is what's been released. This is also national data. And this gets again at why characterizing the opioid crisis using three waves or trying to understand what's happening simply looking at the national data is obscuring what's really happening on a state level, which can be very different from one state to another. Certainly when you lump all of the data together, because fentanyl is so deadly, it shows that our most urgent problem is fentanyl. But the fentanyl problem has been a much more severe problem in some states than in others. Unfortunately, in almost every state, fentanyl is beginning to get worse. On the top left, you're looking at New Hampshire. And because you see a brown line and black line so close to each other, what that's really showing you is that almost all of the opioid deaths in the state of New Hampshire have been driven by that brown line, which is fentanyl. Come down on the left, you're looking at Georgia, and you can see again, the black line is the total. Up until fairly recently, prescription opioids were still the #1 opioid killing people, but really since last January, fentanyl deaths have surpassed prescription opioids in the state of Georgia, but that's a new thing in Georgia, whereas that happened long ago in other states. Top right, you're looking at Washington State, and you'll see fentanyl was also slower than it was, for example, in the Northeast, but fentanyl is again getting worse there. And then on the bottom right in Oklahoma, you see a pretty good trend in a sharp decrease in prescription opioid overdoses, which had been really accounting for most of the deaths in the state, bringing down the total number of deaths. And you really haven't seen much of a fentanyl increase yet. I'm concerned that when we get more current data from Oklahoma, we are going to see fentanyl going up, which seems to be a consequence in part of a trend that was occurring but possibly accelerated during COVID. This is really important to understand, and this is one of the main problems with characterizing the opioid crisis as three waves, which is not only does that obscure geographic differences in the opioid crisis, it obscures demographic differences. The epidemiology of opioid addiction in the United States is critical. Understanding it is critical to addressing the opioid crisis. We roughly have three groups of opioid addicted Americans. The first group is a group that is young. They're in their 20s, 30s, early 40s. Their opioid addiction began after 1996, began almost entirely with prescription opioids. And this is a group that's been switching to heroin. And again, the switching didn't suddenly start to happen after 2011. In many parts of the country, that switching began much earlier. And because these were individuals that even if they became addicted to the pills through legitimate medical use, once addicted, doctors, even in the early 2000s, were not that comfortable giving healthy-looking 25-year-olds lots of pills on a monthly basis for chronic pain. So generally, young people who were becoming opioid addicted would wind up on the black market. Pills are expensive on the black market. Heroin is much cheaper. If that young person was in a region of the country where heroin was available, they'd switch because it was much cheaper or much easier to get. And what we've seen happening steadily since the early 2000s, not suddenly in 2012, but steadily we've seen heroin flood into more regions of the country where it was not previously available to meet the demand for it by this growing number of young people who became addicted through use of prescription opioids, through use that was either recreational or medical. The second group of opioid addicted Americans would be middle-aged individuals. This is, by the way, that first group is disproportionately white. The second group is disproportionately white as well. These are middle-aged individuals who have become opioid addicted through use of prescription opioids, also post-1996. Almost entirely, their opioid addiction begins with medical use. And this is a group that really hasn't been switching to heroin. Even now, as prescribing is trending in a more cautious direction, we have a long way to go, but the trends are good. We're still not really seeing this group turning to heroin in large numbers. This is a group that seems to be doing a little bit better now that opioids are being prescribed a bit more cautiously. The third group are individuals who are primarily survivors of the heroin epidemic of the 1970s. This was an epidemic that really got going in the 60s, bled into the 1980s. Just as we were almost out of the heroin epidemic, the crack cocaine epidemic came in, hit the same communities. This is an epidemic that disproportionately hit inner city, urban communities. These were individuals whose opioid addiction began with heroin. These are folks who are disproportionately Black and Latino. They're disproportionately male. And this is a group that up until pretty recently had been, managed to beat all of the odds. They've managed to stay alive for 40 or 50 years despite their heroin addiction. But now, because of fentanyl and the heroin supply, it's a group where we've seen a soaring increase in deaths. So up until around 2011, 2012, 2013, when you compared these three groups, the group that had it the worst was the middle group. The group where we saw most of the deaths were really in the individuals that were getting pills prescribed by doctors fairly easily, this middle-aged group. But once the heroin supply became so dangerous because of fentanyl or increasingly replaced by fentanyl, that's when deaths in the first group and the third group, the heroin using groups, that's when the deaths in those groups began to really take off like nothing we've ever seen before, just a soaring increase that has hardly let up. How did this all happen? One of the best answers to that question came from a medical director at the CDC, Dr. Len Palazzi. He worked at the CDC's Injury Prevention Center. That's the part of the CDC that works on deaths caused by accidents. And up until the 2000s, dying from an accident in the United States almost always meant a motor vehicle crash. Early 2000s, Dr. Palazzi starts to see that the car crash category is going to be surpassed soon by the category of poisonings. Starts to see poisoning deaths are surpassing car crash deaths. Got to figure out what's going on, goes into the data, figures out quickly because they have the death certificate data that many of these poisoning deaths, really almost all of the poisoning deaths, were prescription opioid overdoses. So now Dr. Palazzi had to really figure out, well, why are so many Americans dying from prescription opioid overdoses? What's really causing this? And to answer that question, Dr. Palazzi did something pretty neat on this graph. What he did was he charted out in orange the deaths involving prescription opioids. And then he charted out in yellow sales for prescription opioids. And what he was showing us is that as the prescribing went up, the yellow line, the deaths went up along with the rise in the prescribing. What he was really saying is that this is an epidemic that's been caused by the medical community, over-prescribing, and that as the prescribing went up, the deaths went up right along with the increase in prescribing. This was done a while ago. This is a little more current. This is also from the CDC. It's making the exact same point. Here, the green line represents consumption of opioids in the United States. The red line represents deaths from prescription opioids, and the blue line represents addiction. And the CDC's point is that as the green line went up, it led to parallel increases in death and addiction. And the CDC's message to the medical community has been that you all need to prescribe much more cautiously. The green line has to come down if we want to see deaths and addiction come down. I can tell you that the opioid industry has not really agreed with the CDC. For really the first several years that these three lines were going up together, the opioid manufacturers were paying scientists to publish papers in medical journals, basically saying that what you're looking at right here is not happening. Publishing papers saying that the prescribing has gone up, but that there's no evidence of any adverse public health consequences of the increase in prescribing. In other words, that we can have our cake and eat it too. More patients are getting their pain treated now that doctors are prescribing more opioids, and there are no public health problems associated with that. Of course, while they were publishing their papers, there was very good evidence that they were leaving out of their papers that these trends were already occurring. I'd say that, a few years after that, really by around 2008, 2009, as opioid manufacturers begin developing so-called abuse deterrent formulations, pills that are made harder to crush for snorting or injecting, and trying to get patents on these new so-called advanced technologies that would solve the abuse problem. As that begins occurring, the language starts to change. You do start to see an acknowledgement that these three lines have gone up together. You start to see an acknowledgement that we have a problem with opioid abuse, but rather than saying that the answer is for prescribing to come down, the argument was that the answer is to make these pills hard to crush for snorting or injecting. But we don't have an abuse crisis. We have an addiction epidemic, and making pills harder to crush isn't making them less addictive. And most people who are addicted become addicted swallowing pills. And most people who are addicted don't actually transition to snorting or injecting. They continue swallowing pills. So it really isn't going to get us out of the crisis, making pills hard to crush. Drug companies have not, and not just the manufacturers, but the distributors, have not simply been saying that prescribing or consumption doesn't need to come down. They've been putting their money where their mouth is. This is data from an investigation by the Associated Press and the Center for Public Integrity, where they looked at spending by the opioid lobby, the manufacturers and the distributors, the money that they spent trying to prevent states from doing things like passing a law that would mandate that doctors prescribe more cautiously, warn patients about risk of addiction, any kind of state or federal intervention that might result in fewer prescriptions. They've done everything they can to fight against, and they've spent $880 million over a 10-year period trying to block those types of interventions. They compared the money spent by the opioid lobby to the money spent by the gun lobby in trying to block gun control, and they found that the opioid lobby had spent 8 times more than the gun lobby had spent in its efforts to block restrictions on opioids. Fortunately, opioid prescribing has started to come down a bit. So you're looking here at oxycodone consumption in the United States, which is the blue line. And this graph ends in 2015. I can tell you happily that that blue line has continued to come down a bit since 2015. But take a look at oxycodone consumption in Europe, which is the red line. It's not even close. It could get close if our prescribing continues to trend in the right direction, and if prescribing in Europe continues to trend in the wrong direction. So I can tell you oxycodone since 2015 in Europe is continuing to go up. You're seeing not just in Europe, but in Asia, South America. You're seeing an effort to increase opioid prescribing by the pharmaceutical industry, and it's been effective. So they could get closer, but really we're just so much consuming so much more opioids per capita than any place else on earth. The number 2 in the world would be maybe Germany and Canada are kind of neck and neck for number 2. We are almost double Germany and Canada in our opioid consumption. Now, take a look at the exact year that the oxycodone prescribing goes up. You'll see that it's 1996. And again, that's why I had said I think the epidemic begins in 1996. And it wasn't just oxycodone that starts to go up in 1996. Hydrocodone also starts going up in 1996. Hydromorphone, which is Dilaudid, starts going up in 1996. Morphine starts going up in 1996. Fentanyl is going up. Every opioid that was on the market before 1996 is the year that the prescribing starts to take off. And it begs the question, what happened in 1996 that caused this very dramatic change in the way opioids were prescribed in the United States? And some of you may know that 1996 was the first year that OxyContin hit the market. And so you might suspect that Purdue Pharma's introduction of OxyContin has something to do with why opioid prescribing across the board starts to go up in 1996. And you would be right. That 1996 was really the year that a multifaceted campaign to change prescribing practices was launched. And this was the year that doctors start hearing that we shouldn't worry about getting patients addicted. We start hearing that if you're worried about getting patients addicted, well, that's irrational, because true addiction from opioids is so rare that you've got opiophobia if you're worried about getting your patients addicted. We start hearing don't worry about dependence, and we start hearing that opioids are safe and effective for conditions like low back pain and chronic headache and fibromyalgia, that it's okay to put patients on round-the-clock opioids, extended release opioids, and have them take opioids every day for weeks and months and years, that this is safe and effective. None of this was true, but these were the messages. And you could be listening to me and thinking, come on, we're supposed to believe that doctors were that gullible to believe that opioids are not really addictive. And I could understand your skepticism. And I would say that, if it had only been the attractive sales reps who visit us in our offices that push, a drug company's products, if it had just been the sales reps coming in and telling doctors, Dr. Kolodny, OxyContin's not really addictive. You can give it to your back pain patients, no problem. If it was just the sales reps, I think we would have been much less gullible. But it wasn't just the sales reps. We were hearing these messages from every possible directions. We were hearing it from pain patient organizations. We were hearing it from our professional societies. We were hearing it from the Joint Commission, which sets the rules for hospitals and mandated that hospitals would treat pain like a fifth vital sign, which was the slogan introduced by the American Pain Society. We heard it even from our state medical boards, which are state agencies that are supposed to protect the public from aggressive prescribing. And from every direction, we were hearing that if you're a compassionate, enlightened doctor in the know, you'll be different from those stingy, puritanical doctors of the past. You'll understand that opioids are a gift from Mother Nature and should be used much more for just about any complaint of pain. Now, all of these different organizations and the key opinion leaders, the doctors leading this parade, had financial relationships with opioid manufacturers. Even the Joint Commission, while it was the materials that it sold hospitals who now had to, the materials from its website, if you were a hospital, you had to follow the new rules to treat pain like a vital sign and show patients the smiley faces and frowny faces. If you purchased the materials from the Joint Commission so that you could figure out how to do this, or if you attended one of their pain conferences, all of the fees that the Joint Commission was collecting for these materials and conferences, they kept, but all of the materials they were disseminating and the cost for the conferences were paid for by Purdue Pharma and then by Johnson & Johnson. So, and even the Trade Association for State Medical Boards was taking millions of dollars from opioid manufacturers. Now, despite all of this money that drug companies were paying for this campaign, I really don't want you to get the impression that this was all about drug companies putting money in people's pockets and saying, these are the lies we want you to tell. Many of the individuals and organizations, even though they were getting handsomely rewarded, and probably would have been thinking more critically if they weren't taking the money, or certainly would have figured out much quicker that what they were promoting was was resulting in a public health crisis. I think many of these individuals and organizations may have really convinced themselves that what they were saying was the right thing to do. Many of the doctors who taught some of these lectures that promoted opioids were not getting paid by drug companies. They were teaching these things because they truly fell for it. They really believed what they were saying. It was common. Certainly there were doctors running pill mills who knew that their patients, really their customers, were addicted and they were selling prescriptions. But many of the well-meaning doctors who started to do this were duped. One of the messages that we would hear over and over again is that the risk of addiction when patients are put on opioids long-term is much less than 1%. This statistic was used everywhere. It was in journal articles, lectures, textbooks. If you came across this in a textbook and if you had the sense to say, wait a second, how can that be true? Much less than 1% of patients are going to get addicted when they're on opioids long-term. How can that be true if you're talking about drugs just like heroin? If you turn to the back of the text, to the back of the chapter in the textbook to look at the reference for that statement, you'd see this: Porter and Jick, addiction rare in patients treated with narcotics, New England Journal of Medicine, 1980. All of that would look great. You might believe it. But let's say you wanted to know what they did in that study. So you went online, you went to PubMed, an online website, because you figured you want to just at least read the summary for the study. Type this in, nothing comes up. Type it in again, nothing comes up. Seems strange. You're thinking, maybe PubMed doesn't go back to 1980. Maybe it's too old, because it was in the 90s and 2000s, everybody's citing this. So maybe you'd stop there and just believe it, but maybe you really wanted to know what they did. So you make your way to the medical library, you pull out the 1980 volume of the New England Journal of Medicine, you'd open it up. What you'd find out is the reason why there was no summary of the article is because it wasn't actually a journal article. What everybody was cited hundreds of times was this. This is the whole thing, a 1-paragraph letter to the editor describing chart reviews where they looked at 11,882 charts of hospitalized patients. And they found in their analysis, they could only find 4 charts out of 11,882 where a doctor or a nurse wrote in the patient's chart of a hospitalized patient that the patient suddenly appeared drug seeking after getting a dose of morphine or Demerol while in a hospital bed. This tells you nothing about the risk of addiction when opioids are prescribed long term. As doctors start prescribing more opioids, patients are getting addicted. The educational messages, or educational in quotes, really marketing disguised as education, the messages that were promoted begin to change a little bit. Doctors start hearing about this concept of so-called pseudo addiction. What that meant was that if your patient, doctors start prescribing lots of opioids, patients are coming in early addicted, and the patient wouldn't come in and say, "Doctor, I'm addicted." The patient would, once they become addicted, they're desperate to maintain their opioid supply, and they're ashamed that they've become addicted. So they'd come in saying I took extra pills because my pain got worse. And so this concept that was taught, really the messaging for the prescriber was, patients coming in early asking for higher and higher doses or running out early. The problem is not with the patient. The problem isn't that the patient became addicted because of the medications you prescribed. The problem is with you, doctor, you're not prescribing a high enough dose. This is under treatment of pain that looks like addiction because really the patients just need more effective pain relief. You should give them higher doses. In other words, if the patient looks addicted, raise the dose. That is really the opposite of what a prescriber should do if they believe their patient might be addicted. If they think the patient might be addicted, they should recognize the patient may be ashamed or desperate for more opioids. They may hide it. They should recognize, you should want to try and talk to family members, get more information. Recognize that if you give a higher dose to someone who's addicted or don't really respond appropriately to this life-threatening condition of opioid addiction, you give them a higher dose, you could easily kill them. And there's no doubt that this concept resulted in many deaths where doctors were really taught to do exactly the opposite of what they should do for someone who's addicted. As more and more opioids are prescribed and more people are getting addicted, certainly in the states where prescribing took off first, we start to have a public health problem. Journalists begin to write about it. Purdue Pharma and the Sackler family get very worried about the bad reputation that their drug is getting. And so this was a quote that came out of an email that became public through litigation against Purdue. What you have really here by Richard Sackler is the framing of the public relations strategy that Purdue Pharma would employ, and that's employed to this day. This is really the argument against any kind of efforts for more cautious prescribing. In other words, don't punish pain patients because of bad behavior of drug abusers, as if we have these two totally distinct groups, when in reality, patients with pain have been disproportionately harmed. And so this idea, we have to hammer on the abusers, they're the culprits, the criminals, that got translated into messages like this that began to appear by authors who did not disclose their financial ties to Purdue or other opioid manufacturers. Here, the headline says it all. OxyContin doesn't cause addiction. Its abusers are already addicts. In other words, the problems that you're hearing about, that's not patients prescribed opioids. That's the subset of our population that are junkies, abusers, criminals who just want to get their hands on these drugs, framing this as if the harms are limited in that latter group. and that opioids are helping millions of people with pain. It wasn't simply this unbranded campaign that changed prescribing practices. Obviously, there was a lot of direct marketing. Drug companies gave lots of money to doctors. And what we've found repeatedly is that the more money doctors took, often in the form of meals and gifts, the more money they took from opioid makers, the more they prescribed. You're looking here at a direct relationship. On the y-axis, you see payments received. On the x-axis, you see the volume of opioid prescribing, and you see they go up hand in hand. How do we bring our opioid addiction epidemic to an end? I'm going to try and wrap this up maybe in the next 10 minutes, if I can, so that we have time for some questions. How do we bring the opioid crisis to an end? Well, we have to obviously prevent more Americans from becoming opioid addicted. And this is where there's really still a critical role for improving prescribing practices. Really, there's a lot we can do about educating the public and social marketing so that the public and patients and parents are better informed, so that parents like Elaine Pazicki in the future would know that when their child or loved one is prescribed a drug that says oxycodone or hydrocodone on the bottle, that it's a drug made from opium, that's a drug almost essentially the same as heroin, so that the public could be better informed. But we also really have to change prescribing practices. And it can be easy to lose sight of how important this is at a time when deaths involving fentanyl have risen and deaths involving prescription opioids have come down a bit. But what you have to recognize is that, in that many of those fentanyl deaths, probably the vast majority of those fentanyl deaths, are occurring in people who developed addiction through prescription opioid use. And until we prescribe more cautiously, patients will keep getting addicted and family members will get addicted if we keep putting it in medicine chests. So we really have to do a much better job. And I don't know that I can think of a better intervention for preventing opioid addiction than mandating that a prescriber warn a patient or a parent about addiction when prescribing an opioid. And I'll go over some data in a moment about the impact of the New Jersey prescribing law. When deaths involving fentanyl are soaring and you have such a dangerous opioid supply, really the only answer to that is to make treatment much easier for people to obtain effective treatment. And to really get people into treatment, it's really two things. It's making treatment easier to get and virtually free, regardless of somebody's ability to pay for it, while also trying to make pills or heroin or fentanyl harder to get or more expensive through interdiction efforts. If we can get the price on the street higher while making treatment more easily available, that will steer many people to treatment. People who are opioid addicted are really not out there having fun. This is not some kind of alternative lifestyle. They are suffering. Many of them want help. But if treatment is expensive and hard to get, but you can buy a bag of heroin for $10, people are just going to keep using because without the drug, they feel absolutely awful. The New Jersey prescribing rules. Let me just tell you a little bit about what we found at Brandeis when we studied the impact of the New Jersey prescribing rules. And we studied this in two ways. We looked at the hard data using the state's prescription drug monitoring program data, but we also interviewed prescribers because what we saw after the law went into effect was a significant change in prescribing practices. That was hard to tease out because when the law was passed mandating that prescribers warn patients about risk of addiction, there were other regs that went into effect at the same time. So to learn a little bit more, we interviewed prescribers, and what we found out was that, well, for one thing, most of the prescribers were aware of the law, which was important because if a law gets passed and nobody knows about it, you can't really expect it to have an impact. And if you see a change, you can't attribute it to the law if nobody really knew about it. So that was good. Media coverage of the law did help get people aware of it. What we found out was that before the law went into effect, only 18% of the prescribers we interviewed were warning patients about the risk of addiction. Only 18% were doing that. In other words, the vast majority were not warning patients about the risk of addiction. After the law went into effect, 95% of the prescribers began to routinely warn patients about the risk. And about half of the one of the other findings was that half of the participants, really a little more than half, were not aware that physiological dependence on opioids sets in almost immediately. They weren't aware of one of the key features of opioids that make them so highly addictive. So if you've wondered, well, why should we need a law to make doctors warn patients about risk of addiction? Shouldn't they be doing this anyway? Well, one of the reasons they're not doing it is doctors themselves don't appreciate how addictive these drugs are. A lot of money was spent misinforming them about the risk. To the extent that they're aware that we have an opioid crisis, they're hearing that, well, that's not about their prescribing, that's about the subset of our population that abuses drugs. They're hearing more and more that it's all about illicit opioids and has nothing to do with their prescribing. So if we really want to see that the public is warned, you really do have to mandate that the prescribers do it. I talked a lot about opioid prescribing for chronic pain. We do need much more prescribing for acute pain. This was a study, many people who wind up so-called chronic pain patients on long-term opioids, they didn't start with a chronic pain problem, tried lots of things, and then somebody said, hey, let's try opioids. We call them chronic pain patients because they're getting opioids long-term. Many of them wound up stuck on opioids after an initial prescription, after surgery, or after an injury or an accident. And so what they found in this study was they looked at the characteristics of an initial prescription. And what they found was the more aggressive that first prescription was, the more likely it was for somebody to wind up on long-term opioids. Patients who took an opioid every day for 10 days, 1 in 5 wound up on an opioid a year later. Take an opioid every day for 30 days, about 40% of patients were still on an opioid 1 year later. This was a study that looked at opioid prescribing to adolescents, basically teenagers and individuals in their very early 20s. This was really a study looking at individuals who got opioids for their wisdom teeth coming out. What they found was that they compared adolescents who got opioids for their wisdom teeth after their wisdom teeth came out to adolescents that didn't get the opioids. And they followed them for a year, basically looking at medical claims data, insurance data. Among the adolescents who got an opioid for their wisdom teeth, about 6% within a year wound up with an addiction diagnosis or an opioid abuse diagnosis in their medical record, compared to 0.4% of the group that didn't get opioids for their wisdom teeth, showing you a much higher risk if you prescribe opioids after wisdom teeth come out. And what's so disturbing about that study is we don't need to give opioids for wisdom teeth. For routine third molar extraction, which is the medical term for wisdom teeth coming out, a review of the evidence tells us that giving patients basically Advil plus Tylenol works better than giving out opioids. In other countries, opioids are not routinely given after wisdom teeth come out. In other countries, opioids are not routinely prescribed after surgery. This was a study published this summer where they looked at different surgical procedures. They controlled for the same procedures in different countries, appendectomy, hernia repair, different procedures. And what they found was that in the United States, 91% of patients who had had one of these surgical procedures were sent home from the hospital with opioids, compared to only 5% in other countries. This may not show up very well, but when you looked at the prescriptions they were sent home with, in the United States, the average number of pills a patient was sent home with was 23, and the median number of pills they were sent home with was 20. Other countries, the average number was 0. The next highest in the world was the Netherlands, which has had a pretty sharp increase in recent years. in part because of the pharmaceutical industry. And yet, even in the Netherlands, if you look at the average number of pills somebody was sent home with, it's 1.6. And if you look at the median number, it was 0, because the vast majority, even in the Netherlands, were sent home without an opioid. We often don't need to give an opioid, even for very severe acute pain. Kidney stone pain is excruciating. This was a study that compared basically injectable NSAIDs to morphine or other opioids for patients in emergency rooms with kidney stone pain. And they found that the pain control was better with less side effects from the NSAIDs. We can't always avoid opioids. There are some patients, for example, who have medical problems where you can't give them an NSAID, but very often we can avoid opioids. Let me just finish up a little bit on treatment, see what we're doing on time. This is the AIDS epidemic, and I'm just trying to make a point here. You're looking at the graph of deaths from AIDS, which peaked around 1995 and then plummeted when we had antiretroviral therapy available, effective medicine for treating HIV became available. We saw deaths plummet. I don't know that we'd see the exact same plummeting, but I really do think we have a medication that's available to us now that would allow us to see deaths from opioid addiction really come down sharply. And the medication I'm referring to is buprenorphine. I'm not just speculating. I'm saying this because we saw this happen in France. The black line here is showing you deaths from heroin in France. The gray line is showing you prescribing of buprenorphine in France. The point being that as buprenorphine prescribing took off in France, deaths from heroin plummeted. And unfortunately, we've never had any taking off of buprenorphine for opioid addiction in the United States because of rules we have that have made really limited access. We make doctors take an 8-hour course. If you're an NP or a PA, it's 24 hours of training that's required. And then you have to apply for a federal waiver. Only 5.7% of doctors in the United States have that waiver to prescribe buprenorphine for opioid addiction. That means 94% of physicians, even if their patients said, doctor, please help me, I'm addicted to opioids, I've heard buprenorphine can work, can you prescribe it for me? There's pretty much a 94% chance that prescriber is going to say, look, I have to find you a doctor that's able to do this. Let me see where I can try and refer you. And we don't have, this is just showing you county level data. We don't have adequate access in many counties to buprenorphine. There are other medicines for treating opioid addiction. Methadone maintenance is an important option in patients for whom buprenorphine might not work. Maybe patients who have a severe mental illness who benefit from going to a clinic regularly and having the methadone dispensed to them. There are other patients for whom maybe methadone would work, but methadone is really second line because it's more dangerous and because patients have to go to a clinic frequently in order to get it. The Vivitrol injection, naltrexone, is also another option, probably a better option in patients with less severe addiction because the evidence supporting its use in patients with moderate to severe addiction isn't great, and it could increase risk for overdose death. Buprenorphine really is still first line. COVID. So there's been a significant impact of COVID on the opioid crisis. We've got evidence that overdose deaths in many parts of the United States, not necessarily everywhere, but in many parts of the country, particularly because it may have contributed to rising fentanyl use, overdose deaths have gone up. We know that COVID has interfered with the ability of treating opioid addiction, and it's even slowed down the litigation against the opioid industry, which means the money that states and counties need, that they're relying on, that could have come from the pharmaceutical companies that caused the crisis and the distributors that caused the crisis, we're not going to, that money is going to come in much slower, in part because of COVID. And, we need it now more than ever, in part because of the economic impact of COVID on states and counties. We know that opioid use disorder increases COVID risks. Having opioid use disorder, taking opioids chronically can suppress your immune system. That's true even if you're a pain patient on OxyContin. It suppresses your immune system, and it's true obviously for heroin. Psychosocial factors associated with opioid use disorder can increase your risk of getting COVID. And if you get COVID and have OUD, there's evidence that you will be hit harder with it. This is a study was just published, I think maybe this week or last week, which looked at OUD and COVID, and they found that if you have addiction, that increases your risk of getting COVID, and that among the different types of addiction, opioid use disorder was number one, followed by tobacco use for increasing risk of addiction. And they found that addiction increases the likelihood that you'll die from COVID, with the increase being the greatest if you have opioid use disorder and if you're Black. Remember those three groups of the three cohorts of opioid addicted Americans? That third group that became addicted in the 70s, that group of that's disproportionately Black and Latino men in their 50s and up, that group has been hit very hard by COVID. We've seen some system treatment changes. Some of these changes in the context of COVID have been helpful, and hopefully they'll continue. What can we learn from COVID-19? We haven't had a model public health response to COVID. In fact, we've had an awful response. Back in January, the United States should have been, there are things we could have been doing to protect the public, which we didn't do. So you might say, well, how can we learn from COVID? But I really think in terms, there are things we could learn for better addressing the opioid crisis, namely for the public health surveillance. Every day we hear the number of hospitalizations in the United States, the positivity rate. We hear about the death rate. We get it on a daily basis. Whereas for the opioid crisis, we still have inadequate surveillance. There's no federal estimate even that's reliable on the number of opioid addicted Americans. We don't know the incidence rate. So we don't know how many people are getting newly addicted to opioids, which means that we can't really measure efforts to prevent opioid addiction the way we should. And even the mortality data on a national level, I was showing you data published in 2020 from 2018. That really just doesn't make sense, not if we want to mount an effective public health response to the opioid crisis. So I will stop here and in the remaining time answer some questions. Thank you.
Thanks so much, Dr. Kalani. And I know we're coming close to the end of our session. Can you answer one question for us that kind of is a combination of some of the questions we've received? Talking about the legislative strategies that you discussed, how can that lead to prescribers not overprescribing and also looking more at alternatives?
I'm sorry, could you ask that question one more time?
Sure. So you talked about some of the legislative efforts that are out there to address this crisis. How can they help with having prescribers not overprescribe or understand the reason that they should not overprescribe, and also look to alternatives, and how that can help the crisis?
That's a great question, and I think it's very difficult for legislators to help prescribers better understand opioid risks. In part, you have state medical societies and a medical community that would say to a legislative officer, to say to a state legislator, when did you all go to medical school that you're going to tell me what to do with my patients? I know what I'm doing. Of course, if the medical community really knew what it was doing, we wouldn't be in this mess. So it really is challenging. And I think that it's hard to get the medical community to listen to you as legislators. I think programs like this and trying to make education for the medical community available that's free of any kind of industry bias, which is really hard to do because a lot of the medical education, even medical education that state legislatures have mandated that their prescribers take, when you look at the content, it's not the kind of content that will promote more cautious prescribing. It's content that's still influenced by these industry messages. So it really is a challenge. I think that by passing legislation mandating these conversations, then you really are in a situation where you can be sure that the prescriber is going to have to know that something about the risk of addiction, because they have to talk to their patients about it.
All right, thank you so much. Thank you so much for your presentation today. I know that you have offered to share your slides with the attendees. So we'll be sending out an email to all of the attendees with a link to the slides as well as the video. of today's presentation. Dr. Gladney, thank you so much for joining us today. Thank you for the research that you've done on the legislation and really spelling out the issue for all of us today. So thank you again.
Thank you. Thanks everybody for your attention and staying on the webinar to the end.
All right, great. So again, thank you to all of our attendees. As I mentioned, we'll have a copy of the presentation sent to you, as well as a recording of this presentation. In the chat feature, we've shared information on sample legislation that Dr. Kolodny has referenced and that he has researched. And we'll also include that in an email after this event. And so I want to thank you again for being part of today's learning activity, for your interest in this crisis. I want to wish everyone a wonderful holiday season, great end of the year, and I wish everyone well. Be well, stay well. Have a good day.
Thank you.